Okay, this is going to be the fourth and final video for the skeletal system chapter. And in this one, we're going to focus on bone remodeling, bone fractures, and disorders of the skeletal system. So the first thing we want to think about is the fact that even when we are done growing, our skeleton still continues to do maintenance, kind of basically replacing old bone with new bone. And so that's what we call bone remodeling, the removal of old bone tissue to make way for new bone tissue. And we would do this to, say, repair minor damages, whether they be like major fractures or even tiny little micro fractures that we might not even be aware of. We also replace old bone tissue with new bone tissue to maximize strength, as in responding to the stress that we put on our skeleton. And we'll also in a little bit talk about how our blood levels of calcium are going to determine whether we are building new bone tissue or like dissolving or eroding away old bone tissue. But the idea is once we are fully grown, it's not like our skeleton just stops being active. We continue to do this constant bone remodeling to maximize strength, deal with the stresses that we put on our skeletons, and so on. Okay, so for this remodeling process to be possible, we're going to need to be able to do two different processes, that being bone deposit, the ability to build like new bone matrix, and then we also have to do bone resorption, the ability to erode or break down old bone tissue, thus creating the potential for new bone tissue to take its place. So, as we've discussed the cell types earlier in this chapter, we probably wouldn't be surprised that the pair of cells that act as what we call a remodeling unit is going to be an osteoblast and an osteoclast. As we've already discussed, right, osteoclasts are the cells that have the ability to do bone resorption. Osteoblasts are the cells that have the ability to do bone deposit. And if we're going to replace old bone tissue with new bone tissue, we're going to need that pair of cells doing those pair of processes. So here's the idea. Let's say we have an area of bone tissue that is relatively older or that has some little micro damages in it. That's where osteoclasts would want to come into that area and begin the process of bone resorption. How do they do that? Well, osteoclasts have the ability first to secrete hydrochloric acid. The idea of secreting that acid is that that basically dissolves the mineralized, like calcified matrix of the bone tissue, basically now softening it. Those osteoclasts then also have the ability to secrete a bunch of enzymes, and those enzymes can then break down the proteins that you find in the osteoid or matrix of the bone tissue. So if we get rid of the calcification and those major proteins, we have basically like dissolved away that older bone tissue. Well, that in turn now creates like a potential space where osteoblasts can now come into that area and start laying down new bone matrix. Eventually, that osteoid of proteins and fibers that are secreted as that matrix can in turn again calcify. So in that regard, what you'll typically find is that osteoblasts and osteoclasts tend to move through bone tissue as like a pair, and hence referring to them as a remodeling unit. The idea being that the osteoclast kind of like creates potential space by eroding or dissolving away the older bone tissue. Then the osteoblast can come into that space and start laying down the new bone tissue to replace the older tissue. So our bones are constantly doing this, but not at a constant rate. So take, for example, spongy bone is turned over faster than say compact bone. And then there are certain places in the skeleton that are turned over more readily because they're more utilized. So not every bit of bone tissue is being remodeled at the same pace. But interestingly, that in a given year, a significant portion of our bone tissue is turned over from older bone tissue into newer bone tissue. All right, so that's the idea of what bone remodeling is and the processes and the cell types that are involved in it. What we can then take a look at, there we go, is the hormonal regulation of this process. So what we have to realize is that we can, of course, remodel our bone tissue according to, repairing damages, dealing with the stress that we put on our skeleton in terms of forces. But we have to remember that we have to keep our blood calcium levels in a homeostasis range. So even if we are putting enough stress on our skeleton such that we would want to be doing more bone deposit, If our blood calcium levels are too low, we might find ourselves doing bone resorption just to kind of remove that calcium from its storage reservoir location and put it back into the bloodstream where it's needed. So what we have to then think about is that there's multiple parameters here determining whether we're going to be at the moment doing bone deposit or bone resorption. And so calcium levels in our blood is one of those parameters that we have to keep in a homeostasis range. So let's look at the hormones involved in regulating blood calcium levels and how they interact with our bone tissue to maintain that. Okay, so first of all, right, we have to keep the blood calcium levels in homeostasis. So there should be a hormone that is secreted in response to, relatively lower levels of blood calcium. And there should be a hormone secreted for relatively higher levels of blood calcium to kind of keep the normal, negative feedback of keeping the homeostasis level as needed. Okay, so let's see what would happen if there were ever too low of a calcium level in our bloodstream. And we can see that in the diagram here. So if the stimulus is a lowered level of calcium, that's going to trigger the parathyroid glands to secrete something called PTH, or parathyroid hormone. That PTH, upon being secreted from the parathyroid glands, can then enter the bloodstream. And in the bloodstream, it will eventually travel to interact with places like your bone tissue. The diagram is giving additional detail about how this hormone secretion also interacts with our urinary system to minimize the loss of calcium in our urine, as well as the digestive tract to maximize absorption of calcium from our diet. But we'll cover those more in detail when we look at the endocrine system later in the semester. For now, let's just really only focus on the skeletal component. So what does this parathyroid hormone, or PTH, do to our bone tissue? Well, it triggers an increased activity of osteoclasts. So in doing so, that means we're going to increase the amount of bone resorption that's occurring. And that means that we're dissolving more bone tissue, thereby taking calcium out of its storage reservoir that is bone matrix and releasing it into the bloodstream to help bring those levels back up to where they need to be. So the diagram shows that here, where we see the amount of blood calcium in the blood, like in the actual blood vessels, seems to be increasing. That returns us to homeostasis. And so at that point, we would stop, secreting that PTH because we've come back to our homeostasis levels. So I can mention, again, there is like a hormone that's going to come from the kidney that's also going to kind of help with this process called calcitriol. But that's going to, again, have more the effect on the urinary system and the on the digestive system, as opposed to the PTH that has the more direct effect on the skeletal system. Okay, well, the parathyroid glands are attached to your thyroid gland, and your thyroid gland is going to secrete calcitonin when your blood levels of calcium are elevated. The whole idea here is to now encourage us to put more of that calcium then into storage. So instead of encouraging the activity of osteoclasts, now we want to inhibit them. If we're inhibiting osteoclasts, that means that we are limiting bone resorption, thereby encouraging a little bit more bone deposit. And so in doing so, we're kind of taking calcium out of the bloodstream and storing more of it into that reservoir that is the bony matrix. So that's the idea of the hormonal regulation of bone remodeling. It's not about the stresses or repairing microfractures. It's instead about maintaining a homeostasis of our blood calcium levels. Okay, so here we've alluded to a couple of times over that we can actually do bone remodeling in order to maximize efficiency of our skeleton when dealing with stress or forces. So it turns out we have a name for this concept, and it's known as Wolff's Law. And that being generally the idea that bones grow and remodel according to the physical forces we place upon them. So for example, if a person is relatively athletic and does a lot of physical activities in which they are putting a lot of forces onto, let's say, their lower limbs, maybe a lot of running and jumping and so on. And if you were to now compare, an X-ray of those bones in the lower limb for that person versus another person who is not nearly as athletic and doesn't do those running and jumping activities, you would notice a stark contrast in the bone density and maybe even in the three-dimensional shapes of those bones because the individual that puts much more stress or forces onto their skeleton is going to have their skeleton remodel in a way to maximize the strength and efficiency in dealing with those forces. The other person that might be more, or like who might be less active, would not be undergoing those same remodeling events, and therefore their bone tissue might show less density or less pronounced curvatures because they're not necessarily putting their skeleton under the same conditions as the more active individual. So there's tons of other, there's tons of examples, but basically Wolff's law states that, bones remodel and shape themselves according to maximizing their efficiency in dealing with those forces. So take, for example, in an adult, we might see a shape of a lower limb bone like the femur having a curvature to it because that maximizes the weight bearing. But in, say, like a toddler or a developing fetus, we wouldn't see that because, of course, if you're not walking yet, you're not then putting those forces onto those lower limb bones, and those lower limb bones then are not remodeling according to those stresses. Similarly, if a person spent, say, a year or more in a zero gravity situation, as in, say, living on the International Space Station, their bone density would decrease because they're not having that gravity and putting their body weight on those bones. Interestingly also, when we look at bones in lab, you'll see where muscles attach to bones, because typically you find little muscle attachment sites have like little bumps or protrusions. The idea is that that bump grows there because that tendon of that muscle is always pulling on that same place. And then interestingly, again, if a person, let's say, had nerve damage where that muscle no longer was functional, that little bump would start to diminish because there's no longer that tug of that muscle on that place anymore. And similarly, let's say we have maybe a person who plays a sport where they use like their right limb more than they use their left limb. They might find that if you were to x-ray those two limbs, you could actually see a difference, where the athlete using one limb more than the other, like a tennis player, etc., might actually have significantly greater bone density in the limb that they use to play their sport, as opposed to like their non-dominant limb. So all sorts of other, all sorts of examples of how an individual skeleton is, responding to the mechanical stresses we put upon them, and that whole concept is referred to as Wolff's law. Okay, so even though bones, of course, are going to remodel according to the stresses we place upon them, that doesn't mean, of course, that a bone is, perfectly prepared for every stresses it could encounter, right? Bones do break. And so we, of course, refer to that event as a fracture. So I'm not going to test you on every single example that we see here in our table of all the different types of fractures that can occur. I'm just focusing on the ones that I've listed for you here. And so let's kind of get a sense of these different categories of how we can classify fractures. Okay, well, don't mind that I might actually go out of order. Let's look at the first one, or the second bullet point first. Complete versus incomplete fractures. This is basically just, describing whether the bone has a kind of crack in it that only goes partially through, as opposed to a bone that is completely broken into two or more pieces. So for example, the image that they're showing over here kind of shows like a partial fracture that would fall into that category of being incomplete, as opposed to what we're seeing over here, where the bone is clearly in separate pieces, and hence would be then a complete fracture. Well, this image, though, also allows us to make another comparison, which is the one above, displaced versus non-displaced. Notice how in this image here, not only is that what looks like there is the femur fractured, but the pieces are also out of their normal alignment. That would imply that this is not only a complete fracture, but is also displaced, as in the bones have been moved from their normal position. As opposed to maybe another fracture where the bones were broken fully through, but do maintain their correct alignment. In that place, we would call it then a non-displaced fracture. So first thing, actually notice, we can actually use multiple of these to describe the same fracture, right? If a bone breaks into two pieces and those two pieces move out of alignment, then not only is it a complete fracture, it is also displaced. Additionally, we can describe that same fracture according to whether the fracture is running along the axis of the bone or more perpendicular to the bone's axis. For example, notice how this fracture here is showing where there is a fracture going across the bone. That would imply that it is a transverse fracture. Whereas if instead, if the fracture went up and down the length of the bone, it would be described as linear. Finally, what's also possible is that when a fracture occurs, if the displacement is significant enough, it is possible for the bone actually to protrude through the overlying skin, basically, penetrating that skin such that the bone is now visible. When that occurs, we refer to that as a compound fracture. Of course, if that does not occur, if the bone does not penetrate the overlying skin, it is referred to as a simple fracture or sometimes referred to as a closed fracture. So feel free to read through the table for more examples of unique descriptions of different types of fractures, but I would only test you on the ones that I've got listed out here in your bullet points. Okay, the next question to ask is, well, when a fracture occurs, how does that fracture repair? So let's look at the events here of typical fracture repair, and notice we give this a time frame of about 6 to 8 weeks in a healthy young adult. No surprise, of course, the time frame could be even a little faster in children who have very quick metabolisms. And of course, the whole process would be slower in an older individual where our metabolisms do slow down. And of course, if a person has any kind of reason that their metabolism is slowed due to hormone imbalances, etc., that also would slow down the fracture repair process. Okay, so first thing to recall is that bone tissue is very well vascularized, right? We learned earlier in this chapter that there are central canals and perforating canals through which blood vessels course their way through the bone tissue. So sure enough then, when a fracture occurs, inevitably there's going to be blood vessels that are damaged. And so the first step of healing or repairing a fracture is that a large blood clot, a hematoma, is going to form in the area of the fracture because of all the damaged local blood vessels. So our first diagram at the left down here, right, shows that our fracture hematoma has formed. So there's a massive large blood clot in the area of the fracture. Okay. The next thing to think about is remember that the entire bone is surrounded by a periosteum, and living in the cellular layer of that periosteum are going to be cells like osteoblasts and osteoclasts, and maybe even some of those like osteoprogenitor stem cells. And so what can happen actually is that some of the cells living in that cellular layer of those membranes in this fractured area can start to become active and start to secrete specifically things like collagen fibers and so on. But instead of making bone tissue immediately, the first tissue that's actually developed in this fractured area is going to be more cartilage tissue. So some of the fibroblast cells that are living in that membrane start to secrete the elements of cartilage matrix like collagen fibers, and they even become eventually cartilage cells like chondrocytes. And so at this point, this development of this cartilage that we're building here in this area of the fracture, we refer to as a fibrocartilaginous callus. Well, what makes sense, hopefully, about the production of this little plate here of fibrocartilage in this area of the fracture is that, like we learned in our previous video, we know that cartilage can eventually ossify over to bone. So the idea basically is rather than build immediately new bone tissue to repair the fracture, it's like we first build a placeholder of cartilage as an intermediary step. And so that's kind of our second step of the fracture repair, is the production of the elements of some cartilage matrix, forming this temporary precursor here, the fibrocartilaginous callus. Okay. It is that cartilage, of course, that can ossify over to bone. And so that's going to occur in our third step, that we form now the hard or bony callus. The thing though is, what's going to develop first is going to be like spongy or woven bone. And so even though this might be the diathesis of, say, a long bone where there should be compact bone there, in the production of this bony callus, it's actually going to be spongy bone tissue at first. But we just learned, right, that bones can remodel. So just because we put some spongy bone into this area of the fracture doesn't mean that that's what has to stay there permanently. We can, of course, start to do remodeling to maximize for stress and so on. So sure enough, our fourth step of the fracture repair is exactly that. where those remodeling units of cells of osteoblasts and osteoclasts can replace the older bone tissue with new bone tissue, replacing the spongy bone with compact bone as necessary. What you might even notice in the end result here is that look at how the compact bone seems to be actually more dense than, say, the area above or below where there was no fracture. That's very common that if we just said a few minutes earlier that bones remodel according to the stress you place upon them, and there's nothing really more stressful to a bone than a fracture, then sure enough, an area of fracture repair will often actually show greater bone density than other areas, basically making it then less likely for that fracture to happen in the same location again. For example, I actually broke my hand when I was in my early 20s and can still feel the little bump where that right fourth metacarpal still has that little enlarged area from where that fracture occurred. And that was years and years ago. All right, so that's the idea of bone fracture repair. So we should definitely know the major events and put them, of course, into their correct sequence. All right, so where we finish out the skeletal system chapter is by looking at the disorders of the skeletal system. All right, the first one we mentioned goes by a couple of different names, osteomalacia or rickets. Even though they refer to the same condition, rickets is typically the name given to the condition when it's affecting children. Osteomalacia is the same thing, but is typically then used for referring to the event when it occurs in an adult. Regardless here, regardless of who it's affecting, the idea of this condition is that the individual's bones are too soft, as in there is an inability for the bone tissue to calcify appropriately. Well, what might cause this? A couple of things. Well, because it requires calcium phosphate salts to do that calcification, then a diet or or an individual who has way too low levels of blood calcium would trigger this kind of condition. Similarly, vitamin D is essential for absorbing calcium in our diet, which means if a person has a vitamin D deficiency, they would in turn have a calcium deficiency, which would again mean an inability to calcify that bone tissue as needed. So that can be especially problematic in a growing young child because, of course, the inability to form that bone density could have an effect on the shape of their skeleton indefinitely and leading to curvatures of bones and things like that that shouldn't be there. So when it's diagnosed, especially in a child, that's where, of course, making sure there's plenty of calcium in the diet and sunlight exposure, because you need sunlight on your skin to activate the production of vitamin D. So sunlight exposure, plenty of calcium in the diet, those are the kinds of things that are going to be recommended, whether it is a child being diagnosed with rickets or the same in an adult. All right, another thing we can look at in terms of skeletal system disorders is osteoporosis, and that's what we're seeing diagrammed for us on this PowerPoint slide. Notice how the image on the left shows normal bone, whereas the image on the right shows osteoporotic bone. In general, osteoporosis is more prevalent in females, and that's because females undergo hormonal changes in middle age as they go through the event known as menopause. So a postmenopausal female having lower estrogen levels actually ends up in a situation where their bones undergo more resorption and less deposit. Well, that's an issue because if you're not doing bone resorption and bone deposit at equal amounts, then that means you are slowly losing and losing bone density. Now, careful here, this is not then soft bones like we saw in rickets or osteomalacia. That's, of course, where there's a lack of the mineralization. Here is where there's just literally missing bone tissue. And in that regard, those bones become more brittle. So not soft, but brittle. And with that brittle nature of the bone comes then an increased likelihood of fracture. So no surprise, older females that are postmenopausal are at higher risk of fractures and have to be especially careful when doing physical activities because even a minor fall could lead to some pretty major skeletal fractures. No surprise, of course, there are plenty of medications that a postmenopausal female can take to minimize that effect. All right, and then finally, the last one we can mention is Paget's disease. This one is where a person has a condition that leads to their body producing excess bone tissue kind of haphazardly. So kind of excessive bone growth that is done irregularly. So imagine instead of Wolff's Law triggering bone deposit in the places you specifically need it, instead, Paget's disease is where sporadic excess bone growth occurs. It's not quite understood what causes Paget's disease. There's some research that shows it possibly having some kind of genetic component. Some, though, other studies show some environmental factors triggering it. But either way, what's unfortunate is that if that excessive bone growth starts to, say, protrude into vital organs, it can actually spill over into causing issues within other organ systems. All right, but basically those are the major disorders that we're going to discuss for the skeletal system chapter, and that actually brings us to the end of that skeletal system. All right, let's stop the recording.